A very good day to you both, and welcome to this Zoom panel discussion hosted by Tricontinental, the Institute for Social Research based in Johannesburg. My name is Anna Majavu. I'm a journalist at Newframe, and I'll be facilitating this discussion on the right to dignified healthcare work and dignified healthcare for all. With us here today are Mzikazi Nkatha and Dr. Basani Baloyi. A very warm welcome to you both, Mzikazi and Basani. Mzikazi Nkatha is a frontline health worker. She's the Eastern Cape provincial convener of the Young Nurses Indaba Trade Union, the former SAFTU local secretary for Nelson Mandela Bay, and she's a community and gender activist. Mzikazi works for the Department of Health as a forensics pathology officer and previously worked at Netcare 911 as a life supporter, treating and transporting sick and critically injured people. And Mzikazi is also part of the Labour and Community Media Forum in the Eastern Cape. Thank you very much for joining us, Mzikazi.
Thank you, Anna.
Thank you. Dr. Basani Baloyi is a feminist development economist and activist. She's Oxfam's inequality lead in the Economic Justice Unit. Basani has 10 years research experience. She gained her research experience working in academia at the Centre for Competition Regulation and Economic Development, Corporate Strategy and Industrial Development Unit, focusing on issues of industrial policy. And she's also the former Director of Industrial Policy and Acting Chief Director in the Industrial Procurement Unit at the Department of Industrial Policy. Thank you very much for joining us, Dr. Baloyi. Basani.
Thank you so much, Anna, and hi, Mzi. Lovely to meet you.
Nice to meet you too, Basani.
Good. So, Basani, maybe we can start with you. So Oxfam's just launched a campaign called Care for Carers, and you've done that in conjunction with Mzikazi's union, the Young Nurses Indaba Trade Union, as well as the Treatment Action Campaign and a few other unions. Can you tell us about the research you did which informed this campaign?
First of all, thank you so much for hosting us and just for this conversation, a very pertinent conversation in this time. Basically, what we were interested in understanding, or actually it was something that has been understood, right? Especially if you are a healthcare worker, which is that there is a definite link between working conditions that healthcare workers find themselves in, and then the quality of care that is delivered to patients, right? And society at large. And what the report basically is looking at is the various structural drivers that lead to poor working conditions, particularly for nurses and community healthcare workers, given that they really are the backbone of the healthcare system, especially nurses, given their numbers, right? So looking at the various structural drivers that lead to poor working conditions for these workers that then compromise the healthcare system and lead to the poor quality of care, which we argue is also responsible for why South Africa has one of the worst health outcomes. It's a contributing factor, basically, in a nutshell.
And what were some of the structural drivers that you found?
Right. So we found what may be called as three triple threats or triple threats, right? The first being an underprovided public healthcare system by the state, where there's been a lot of budget cuts, austerity over the last few years, and that has also meant basically a hiring ban on healthcare workers. So there's been a hiring ban on healthcare workers. There's been a wage freeze, and also what's happened is a de-skilling. The cost containment has also led to a de-skilling of the healthcare profession, where you find that healthcare workers or nurses that are, or even community health, nurses that are employed at a particular grade are now being shifted to higher grades as a way of containing the costs of their employment. So you would rather employ an underqualified nurse to take on the position of a higher qualified nurse in order for cost containment issues. We've also seen a reduction in the administrative support that is given to healthcare workers, such that they end up taking up administrative support as well as having to take care. So basically, there's a budgeting cost containment, and these are the various ways, right? And then we've got this private healthcare system that basically contributes to almost half of the healthcare budget expenditure, right? It's very big, and it only supports a minority. And it's been extremely extractivist, to the point where the payoffs to shareholders are so incredibly larger than the actual profits that are made. And at times, for certain companies, what you find is that they are paying off shareholders whilst making losses, right? Instead of reinvesting that money to the healthcare system, and particularly workers. A system, a private healthcare system that is highly over-resourced, while the public healthcare system that serves the many is under-resourced. But like the big contribution to the report is the third area, which is the fact that there are particular gaps in labor policy and practice, right, that have led these types of employers, the public and the private healthcare system, to further exploit healthcare workers beyond the scope at which they do, right? And so it is these labor policies and labor legislations and practices that we look into, which are not well understood or known. So those are some of the structural drivers that we look at.
Thank you. And maybe Mzikazi, you could talk to some of those labor issues. I know you've been at the forefront of the struggle of community healthcare workers. And I think you've mentioned previously they only earn 3,500 Rand a month and they don't get any benefits. And then maybe you could also talk a bit about what Basani was saying with regards to hiring nurses who are paid quite low rates to do the work of much more senior people, because everything is being determined by costs.
Okay, thank you, Anna. So, firstly, you can look at the point of discussion today, which is talking about the right to dignified health, which only exists in paper. That's the first point we should be looking at. All these policies are drafted, circulated everywhere, but they only exist on paper, which is what is causing all these problems that Basani has touched on right now, where you will find workers employed, but the scope of duty that they are doing is not in line with what the person was employed for on the first day of employment, which is a big problem that is also driving us into understanding more that the health system itself, it has been changed it has been capitalized, let me rather put it that way. So if now you are a poor person from a poor community, you will receive that health system that is not quality. You won't get any quality medication. You won't get also any quality treatment from the person who is treating you at that particular moment, because of the same issues of poor employment that is being done by our government. All clinics, if I can mention, they're working on skeleton staff. All hospitals are working on skeleton staff. So everywhere you go, even my sector, which is forensic, is also working on skeleton staff and also not applying the policies. So we have these policies that are there, but not practiced. And also, when we come now as labor, wanting to force things to be done correctly, remember, you must go again and lodge a grievance to this very same person who is the custodian of this policy, who can manipulate around this very same policy. So we are faced with that big challenge. We don't know when, but we do believe that we can overcome it. We do believe strongly in that. And also another thing, I think we are faced with the fragmentation between these two sectors, which is public sector and the private sector. There's this big wall that is built so that we don't find it easy for ourselves to unite and to be talking things in one voice. Remember, if you work in the private sector, you're the most vulnerable one. They are most vulnerable more than the ones that are working at the public sector. But we are trying by all means to close those gaps because we believe that nationalization of health is the only thing that can come to our rescue. It can come to our rescue in many ways. It is the only thing that can even bring into, it can dismantle, if I can put it that way, the hierarchy that is caused in our workplaces. Because now, if you're just an ordinary employee who is at a floor level, you have a manager who is playing the hierarchy and making sure that they're shifting all the blames around the workplace and shifting them to lower level workers. For example, Anna, I'll make an example with the PPE. The PPE in most workplaces, we're fighting because the PPE is only reserved for professional employees. Meaning now it is only given to professional nurses and also to doctors. The people who are community healthcare workers are not allowed to be given PPE. The general assistants are not allowed to be given PPE. The people who are sitting at the administration sector are not allowed to be using PPE. So now, remember, for any patient arriving in the clinic, that's by the admin. And nobody is labeled whether they do have COVID or not, if you can use the example of COVID. So the first person to be infected is the admin who is recording in this patient. So those are the most big challenges that we are really faced with. And I want to say this pandemic, yes, it's deadly and it's so painful, but it has assisted us in a way to take everything out of these walls and put it in the naked eyes of the society and of the whole world to see that this health sector is been crumbling and it has collapsed a long time ago, but now with the COVID, it has made things to be more, and the employer is more resistant on applying the policies. They really don't want to apply the policies.
Thank you. And I see along those lines, the report actually mentions that Netcare, the Life Group and Mediclinic have paid out 19 billion Rand to their shareholders while collecting a net profit of 11 billion between 2016 and 2019. And I see the report has also found that the private healthcare system is only available to 16.4% of the population. 72.9% of the white population has access to medical aid and use private hospitals, compared to only 9.9% of the Black population. And I think, as you're saying, Mzikazi, COVID has brought that to light. I mean, those figures have been around for a while. We've seen the inequality, but now we're seeing the public health system, as you say, it has almost collapsed. And maybe you can add on the issue of the skeleton staff that you were mentioning. I mean, how possible is it now that we are in the COVID pandemic and there's these huge inequalities between the private and the public health sector? How possible is it for the public health sector to actually bring in more nurses and healthcare workers? I mean, does it not take a very long time to train a nurse or a pathologist like yourself? Can they be brought in overnight to assist with the pandemic? Because this is what we're hearing from the government every day, that they've advertised for 8,000 new nurses. And are those nurses even out there?
So, Anna, this can be corrected. It doesn't even need a month or a week. It can be corrected because, number one, we are sitting with a lot of people with qualifications but unemployed sitting at home. That's number one. Number two, we are sitting with the cut of budgets, which are supposed to be feeding these workplaces by employing new people and also by bringing medication so that when communities are coming sick, they get proper medication. But what we see daily is a cut off of budget. Also, look at how queues are so long. Round about 5 in the morning, you will see in all clinics already there's queues, which is also talking to this inequality that you just mentioned. And these queues, again, they're not anything new. They didn't start because of COVID. They were there even before COVID. So now, look now at the issue of having to work with skeleton staff, and with the skeleton staff that you were working with, some of your colleagues being COVID positive, which is reducing more on the number that you had and putting more burden on the ones that are at workplace, which they work and get so exhausted so much that they can't produce any quality services anymore.
Absolutely.
And then on top of that, Anna, the department also doesn't want to pay people, because now with the skeleton staff, they are forced to allow staff members to be working overtime. When people have worked that overtime, they don't want to pay their overtime money. So we are really fighting with a virus that is more than even this pandemic, which is COVID, which I think we are only faced with the corruption. I believe that it's corruption that has brought us to where we are today. And also, this thing I've mentioned before, that the capitalization of things, where everything is just spent to make profit instead of looking at the quality that will be produced and the care that will be produced. So those are the challenges that are making us to be working in this skeleton. And you can't even mention to the employer that you need to beef us up, you need to beef staff. The only answer you get from the employer is that, do you still value your job? Do you still want to be here? Because for me, I can just stand on the street and call anyone to come and replace you. Which is also talking back to the fact that now you can go in any workplace. You will find people with no qualifications doing jobs that are supposed to be done by people who have certain qualifications to be doing those particular jobs. Let me take you briefly to the issue of the CHWs. The CHWs are only people who are supposed to be visiting communities and also encourage people who are defaulters to continue taking their treatment. But you will find community healthcare workers doing less work inside the clinic. You will find them in dressing rooms, dressing patients. You will find them in dispensary, giving out medication. Those people didn't study those. They do not qualify to be doing
That's
those.
it. You know, Usis Mzi put it so beautifully and succinctly in calling it a skeleton staff. Insofar as we have one of the, like her organizers or her colleagues is a woman by the name of Maredi, who is in a Limpopo registered nurse who is part of Wainitu, who speaks about how on a daily basis she is forced to play God, right? By basically in her determination of whose child deserves to live, whose child does not deserve life, simply because she's one person taking care of so many patients, all of whom need support now, right? And basically the chronic understaffing of the healthcare system, it basically prevents healthcare workers from fulfilling their jobs, right? And there are also a lot of mental issues that come with this, right? And a lot of anxiety that comes with this. When you are forced to play this kind of godly role. And of course, it leads to tensions between healthcare workers and patients as well. And there's, which often enough lead to violence, right? We hear of healthcare workers, for instance, that work in mental institutions, right, getting raped by patients because they are not the security personnel that is required to be there, or the number of staffing complement is such it's at such a chronic low that they are vulnerable to these types of violences, right? So, and I think that's the part of it, is that we are not, in speaking about what the chronic staff shortage is, we actually need to put it at its most personal, what it means in the interpersonal interaction between healthcare worker and patient, right? Where in sometimes, given the structure of what we've painted, which is an underprovided public healthcare system, an extractive private healthcare system that extracts also in the form of the fact that, you know, medical tax breaks are given to the middle class, or basically medical tax breaks subsidize in a way private healthcare system, right? And contributing to these resource inequalities, how that whole structure then puts at the interpersonal level the tension between healthcare workers and nurses, where patients feel as though healthcare workers are not doing their job, right? But also healthcare workers are then let down by the system because they are not well taken care of. But another issue that Maredi raises, which I think is really very, very critical, is the level of precarity in the private healthcare system as well. We often think of the public healthcare system as worse performing on working conditions. Indeed, it is, right? It's deplorable when a healthcare worker does not have enough PPEs or does not have enough medication and does not have enough XYZ in order to carry out its job, and also has to work extended hours, right? However, there are also precarities in the healthcare system, in the private healthcare system, that Mzikazi points out that I'd like to elaborate. The most critical one is the fact that the private healthcare system is the biggest employer of healthcare workers through labor brokers, right? It dominates that, right? Now, what we are finding is that, of course, what happens to these labor brokers is that they are less paid, they're not protected, they don't have medical aid themselves. You know, we are talking to healthcare workers who have been exposed to COVID, working in these institutions, and yet do not get free medical attention from that space, right? Which I think is abhorrent. And what you find with these workers is that they move from institution to institution. They go from this private facility into the public healthcare system, into this other place, there's like a cross-breeding. It will be one healthcare worker moving in between institutions, just so that they can eke out a living and make and survive, right? And yet they are not given the protections of medical aid or any free medical attention. They are out there exposing themselves to this virus, but they are not protected at the most basic humane level possible. And so no pension, no medical aid, underpaid as well. And as one, Ulebu, who is also from Wainitu, who's a registered nurse with a labor brokering agency, she mentions the fact that labor brokered workers in those institutions are the most vulnerable because they'll be often blamed for any mishap that happens, right, within that institution. So I think this becomes a very critical point, because as these shareholders are extracting more and more and more, they are doing that at an actual cost they are also creating greater precarity in the process of the extraction. It is breaking the backs of these nurses, these healthcare workers, by putting them in contracting positions that make it extremely difficult for them to basically survive, simply because they are trying to not pay them what they need to pay, and also provide the types of benefits that they should. Umzi also mentioned the fact that, healthcare workers are more susceptible to working extended hours. And again, when I just want to bring you back to the point of, there is the labor law gaps that actually help to actually engender that, which is in the BC in the Basic Conditions Employment Act, right? There are particular protections there, or basically exclusions, right, that exclude particular categories of workers from work time protections that would protect how long they are allowed to have breaks, their overtime, whether or not they can take, like how many hours in a week that they should be working. So basically there you find that workers that work, that are paid above a particular minimum threshold, right, or actually are excluded from, and who are also emergency workers, are excluded from particular work time protections. And it's this big gap within the labor law that then allows for healthcare workers to actually work up to 24 hours with no break, right? And how can you actually be providing quality healthcare service if you're working at that intensity, right? With no break, you're on your feet, right? You're running around on your feet, and you with limited breaks. What is the impact of that healthcare worker on the care work that they also provide at home? Since they carry the double burden of this care, having to take care of their households. Many of these healthcare workers are single parents. So what happens to their children as well? And where you have healthcare facilities as well that are not gender sensitive, right? Even more worse for community healthcare workers who do not operate in facilities, but like their facilities are them being on the road and actually meeting various households. What is the nature of their work? and the nature of their unpaid care work at home as a result of that, with very little protections. So, you know, these are the various angles that we look at in the report, and just inspired exactly by the reflections and experiences made by what Umzi is saying concerning the conditions of work.
Yes, and I mean, we can just imagine, you know, doing a 12-hour shift in an emergency department or casualty, and then hopping in a taxi and going across town and doing another 8-hour shift, maybe in intensive care, and, you know, not really even having a break. How terrible that is for the nurse. And of course, the former Labour Minister promised, I think it was in 2010 already, to ban labour brokers, because this sounds like it's one of the problems. I mean, surely labour brokers are not even necessary in the private hospitals. If public hospitals and private hospitals had proper nursing training programs and they didn't cap the budget or freeze posts, wouldn't that solve the problem somewhat? I don't know if you want to come in here, Mzi, and talk more about the labour broker issue, or any other issues related to your work.
I want to come in exactly on that point of the private, which is using labour brokers. It is also the same with the public sector. I'll give you an example with myself working as a forensic pathology officer, where I must be at work from 7:30 till 4 o'clock. And then from 4 up until the next 7 in the morning, I'm on standby waiting for any call that might come in saying there's a police case that I must go and attend. So remember now, having those cases at night, and then again in the morning to be at the work facility and conducting postmortem with sharp tools where you're feeling so sleepy and you're busy eviscerating bodies. So this sickness or rot is really in all these sectors, and the only thing I believe that we really need now is the resistance that we can pull together, uniting together, and pull a strong fight against this illness. And another thing that Basani touched on, which is a really thing that we should be looking at, is the fact that most of us as frontline workers, it's women. And these women is single parents who do not even own property, who do not own anything. For example, look at the CHW, who is only earning 2.5, and from that 2.5, the person must pay rent and must make sure there's food on the table, and also must make sure they travel to all these different stations that the department will require them to travel to, of which the department doesn't even provide transport for them. Mm-hmm. And also, while they're busy visiting these places, they get robbed, they get masked, they get all sorts of violence, which also again happen in the facility, where in most hospitals, maybe you do know, Anna, I'm not sure if you can check at Livingston or at Dora. There's a lot of structures that are just standing there that are not used, who are now places where nurses get to the rape and also the patients get to the rape. So it's everywhere. It is everywhere. Yeah, I'll stop there.
Do you want to comment there, Basani?
Can I? Yes, there's so much like what Umzi is saying that is like so fundamental. I mean, just to touch on an earlier point, right, around that you were making around the hiring of healthcare workers especially within this COVID moment. And she mentioned the fact that, you know, there are many unemployed healthcare workers out there who are not being employed. But also the problem here is that the way in which we are responding to COVID is not in a systemic way. It really is in a bandage kind of approach, where prior to COVID, we sat with a chronic understaffing and what Umzi was talking about, a skeleton staff. We are now pushing for the hiring of healthcare workers, but we are pushing for them sometimes as volunteers, right? Coming back into the space, and also under short-term contracts. So they are only coming back for this period, and rather than saying, actually, we need them for a longer-term period as part of the healthcare system. So basically, once the pandemic is over, we will still sit, and even if we are able to hire all of the ones we need, we will still sit with an incapacitated, chronically skeletoned healthcare system that is not able to deal with whatever shock or even the current day-to-day shocks that we face in our healthcare system. And I think that is a problem, and in fact, it's one of the demands of the campaign and in the Wainitu as well, that we need to ensure that these new healthcare workers coming into the system are actually on permanent contracts, on permanent and secure contracts, to deal with a system that has been chronically underprovided for many years, right? And to deal with the hiring ban that has absolutely nothing to do with the healthcare needs of patients, but rather to do with the bosses in the DOH and wherever. So that's one thing that is, I think, very critical. I love the point that also makes a distinction that Mzi mentioned, that makes a distinction between, you know, the work that happens within a facility and in the work of a community healthcare worker, which is basically where her work is the community. It is the households that she goes and visits. The way in which the labor law is constructed at the moment in terms of worker protections, it does not cater to the work of a community healthcare worker. In fact, we actually even ignore them, right? Because we treat them as volunteers in many instances. So when it comes then to the issue of transport, how do we ensure that that transportation is seen as part of her work, right? Such that it doesn't lead, so because what happens now is that although these healthcare workers, community healthcare workers, are meant to be reimbursed for their transport, often enough they are never reimbursed, right? So they are having to pay from this 3,500 Rand for transport to go and see patients and are hardly ever reimbursed for that. Then we also speak, Umzi touched on the issue of night workers, or when you're working in the night shift, and what happens to your transport. The currently in the Basic Conditions Employment Act is that employers of night workers, right, must ensure that transport is accessible, right, to healthcare workers. They don't have to ensure that transport is provided. So there's a difference between accessible and provided. In the one, it says basically there needs to be some kind of a route, a taxi route somewhere, right, close by, and then this night care worker who comes off from a 7 a.m. shift or comes whenever they leave to then have to go back into the streets, and these are women, and therefore expose themselves to great violence, right? So that is a problem, that's a system problem. Even more so now, within a COVID crisis, where we are seeing healthcare workers who are exposed to this crisis, right, who are exposed to these conditions, and often enough are they contracting the virus, and are moving from one institution to the next. And the reason they move from one institution to the next is because they are underpaid, right? And therefore are having to moonlight and do piece jobs in order to make ends meet, basically. So they move from one institution to the next in order to meet their needs. And then they are taking public transport as well, going to work and then coming home. And if they've contracted the virus, how many people are then exposed? So one of the demands of the campaign is that transport has to be provided, particularly for healthcare workers that are testing, tracing, and are exposed to the virus and also have contracted the virus, not only for their own healthcare, but to ensure the well-being of society at large, right? So basically, we want the legislation to change such that for community healthcare workers that are out there doing these rounds, tracing, testing, and as they do, that the transport system must be, the public transport, they must be given free and adequate transport. And similarly, particularly for night care workers who do not have their own private cars, they need dedicated transport so not only for the immediate needs of COVID, but also because they are most exposed to this type of gender-based violence.
Yeah. So it's obviously a great campaign, Oxfam's Care for Carers campaign in conjunction with the unions. I mean, it covers the broad range of all the kinds of oppression that healthcare workers are facing, gender-based violence, lack of transport, poor pay, skeleton staffing. We've got about 2 minutes left, so maybe I could ask both of you to just talk about the way forward for this campaign. It's a great campaign, obviously, and how are we going to make some of these things happen for nurses? Because the situation that you've described is far worse here than it is for nurses in any other countries. I mean, even the fact that you have to work a full shift as a forensic pathologist, Mzi, and then be on standby for the night and go back on the shift, that shouldn't be happening. Like, you should have a contract which has a standby roster, so that if you're on standby, you're not working the next day. And nurses shouldn't have to be paying for their own transport either. So what's the way forward, just briefly from both of you? How are we going to get some of these changes and made a reality?
Do you want to go ahead, or should I?
Go.
Okay, so basically, we have come together for this campaign. I will talk about the first demand of the campaign, which we are about to launch. We're busy tying it down. And the first demand basically looks at the most immediate need, which is free mass testing, free mass and regular testing, free medical attention, and adequate PPEs for all healthcare workers, right? And by healthcare workers, we are not only talking nurses and community healthcare workers, we are also talking about the people that, the workers that Usisi Mzi was talking about, which is the cleaning staff, at these facilities, the admin staff. Basically, they need to be provided with adequate PPEs, and they need to ensure, we must ensure that they have medical attention. We're currently doing a poll of these healthcare workers, and we are finding that many of them do not have these things, these very basic things. Many of them have not even been trained on the National Infection Protection Control, right? The NIPC, that looks at the various ways in which healthcare workers need to protect themselves within this COVID time, right? So that is the first demand, and we're going to put out a petition. We're going to have a range of activations, and we want to call upon South Africa and even the global community to actually support, because many of these, the key private healthcare providers are actually multinationals. Yes, they have a base here, but they're multinationals. So the kinds of ways in which they're acting in South Africa are similar to how there are similar experiences in other parts of the world as well. So we are seeing this as, yes, a national campaign, but it's actually quite global, right? And we are obviously calling on the health ministry to act right itself. But that is basically, it's a long way. We also have another campaign on the NHI as well. We have a campaign on public transport or ensuring transport and a range of other issues. But the main one that we are looking at now is the most immediate, which is on free mass testing, PPEs, and medical attention. So please follow that. Yeah.
Yes, thank you so much. And can we have some closing remarks from you, Mzikazi?
Okay. Just to add on what Basani has just mentioned, also we are pulling so much on the fight of labor unions to be putting aside their emblems and focus on the real issue which are affecting all workers at workplace, because those problems do not discriminate against which trade union you belong to or which federation you belong to. So that's also another campaign that we are really pulling to make sure that we build this resistance that I mentioned earlier of fighting back to the employer. And also another thing that another campaign that we are working on is of also educating and training mostly the CHWs and also the community members on building up their own food support by having small gardens at home, and also make sure each and every clinic in the Nelson Mandela Metro has a garden. By doing that, we are also trying to shift away from depending entirely to this government of ours, who is rotten and who is only sucking the blood out of us and not providing any sort of help for us. That is also another campaign that we are busy with in the Nelson Mandela Metro. So it's those food, that means, yeah.
Thank you. So that's a very strong campaign. It's against privatized healthcare, against the profits that are being sucked out of the public health funds by these private companies. And it's a call for unity for all the unions, a call for each household to try and start growing their own vegetables, which, you know, is a tactic that's been practiced by many resistances worldwide, including the Palestinians. They had their Intifada gardens so that people can be a bit more self-sufficient. And then for any members of the public out there who aren't health workers, a call to join in the actions of this campaign. And you'll be able to find them all on Facebook and social media, and we'll put up the links. I'd like to thank you, Dr. Basani Baloyi of Oxfam and Mzikazi Nkatha of the Young Nurses Indaba Trade Union. Thank you so much for joining this Zoom discussion today. It was wonderful to hear from you both, and it was wonderful to hear about all the work you're doing. Thank you so much.